As X-rays travel through the body, they are either absorbed or scattered. The amount passing through is dependent on the tissue, and these differences create a sort of shadow image. As X-rays are scattered or absorbed, some energy or radiation dose is deposited within the tissue and is the origin of the unwanted side effects of X-ray imaging. The X-rays can cause DNA damage with increasing radiation dose, leading to stochastic effects, also known as statistical effects, such as cancer. High-dose X-rays can also cause cell apostasis, which can cause deterministic effects, such as skin injuries, cataracts, or cardiovascular disease. While small doses can cause cell death, there is no clinical effect until sufficient cells die, which is the threshold for these effects. As doses increase beyond the threshold, the effect gets more severe. The scattered radiation means that people close to the patient are also at risk from the radiation, though they may get a much lower dose than the patient themselves. We use a number of terms to measure the impact of radiation exposure. The first is absorbed dose, which is the energy absorbed per unit of mass. This is a measure in Gray, or 1 joule per kilogram. This can be used to monitor doses against the threshold for tissue reactions. However, for stochastic effects, we look at the overall risk, including all tissues exposed, using effective dose, measured in sieverts, which includes weighting factors for different tissues. Measuring patient doses directly is impossible, so X-ray systems report a range of values to help monitor exposure. The first is the cumulative Kerma, displayed in Gray or milligray. This is the dose delivered to a defined reference point, which roughly approximates the skin entrance, but varies depending on the patient's size. This value gives a rough measure of the possible risk of skin injury. Newer technology is allowing modeling of the different areas of skin exposed during procedures, which can be more accurate. For a better measure of the total radiation delivered to the patient and the risk of cancer, the area exposed also needs to be considered. This is done through the use of the dose area product, or DAP, sometimes called the Kerma area product, measured in Gray centimeters squared. Most systems also report the total fluoroscopy time, but this doesn't include the frame rate or exposure settings used, so it's a poor measure of the radiation exposure. Safety standards to protect against the occupational exposure to radiation are established in many jurisdictions. These enshrine the principles of radiation protection: justification, optimization, and limitation. Justification is ensuring that the benefit from using radiation outweighs the risk. Optimization is using the least radiation to achieve the desired outcome and is sometimes referred to as the ALARA principle, as low as reasonably achievable. Limitation puts a cap on the radiation doses workers and the public can receive. Staff and patient doses from interventional procedures can be reduced in a number of ways. Firstly, the imaging system and protocols should be carefully set. The system should default to low doses and frame rates but offer a range of modes to provide sufficient image quality. Next, the foot pedal should be controlled by the operator and disengaged immediately after image acquisition with aggressive collimation. Good collimation avoids exposure of neighboring tissues and reduces scatter. Magnification can be used sparingly as they increase dose. If low-dose DSA or even safe fluoroscopic runs provide adequate visualization, then they can be used instead of high-dose DSA protocols, of course. Another key is to keep the patient away from the X-ray tube and close to the detector to minimize skin dose. Scattered radiation is primarily back towards the X-ray tube, so where possible, operators should stand on the detector side during lateral views. In addition, having the detector close to the patient can help reduce scatter in the room. Avoiding steep angulations which increase the thickness of tissue the beam traverses will also decrease dose. Dose audits which compare local doses to published dose values for similar procedures can highlight areas for potential further optimization. Sometimes high patient doses are unavoidable, and if there is a risk of skin injury, patients should be followed up after reaching local trigger levels. Typically 5 Gray reference points Kerma or DAP greater than 500 Gray cm squared. To further reduce operator doses, personal protective equipment can be used, including including 0.5mm lead aprons, thyroid shields, and table-mounted lead skirts. Sealing suspended shields and lead glasses can help reduce the dose to operator's eyes from scattered radiation. Follow these simple steps and you'll soon be ready for action. Good luck!